We're going to return now to England. Going to invite Steve Bush to give the third talk. He's medical director at the Leeds teaching hospitals, responsible for unplanned, emergency care. He's had a role also in training. But Leeds was an early adopter of Scan4Safety, and he's going to give us a bit of a perspective of then and now. So over to you, Steve.
Good morning, everybody. Thanks very much for the introduction. My name's Steve Bush, Medical Director for Operations at Leeds Teaching Hospitals. I'm an A&E consultant in my, my clinical practice, and I chair the Scan4Safety programme in Leeds Teaching Hospitals, but also in the West Yorkshire Association of Acute Trusts. So, unplanned care has been around a long time. This image is taken from a book from the South Netherlands, written in Flemish, translated as the Book of Property of All Things. And you can see here a great image of a very wise doctor on the left with a whole bunch of patients desperate for his intervention. He's clearly a multidisciplinary, multi-specialty clinician. He can do orthopedics, he can do a whole range of interventions. But this poor chap in green in the middle, clutching his chest, is clearly concerned that he's having a heart attack, and he's waiting behind a chap who's just vaguely worried about the colour of his urine, while our clinician is doing something strange to the arm of the first person in front. So although there's some great elements here, and that multi-specialty approach, there's no system, there's no approach to prioritise patients, and in essence, it needs work. Fast forward 540 years and acute trusts are a very different position. There's a huge range of services offered in a variety of contexts, outpatients, wards, emergency departments, operating theatres, radiology suites, etc. But also it's no longer just the doctor. We have doctors, we have nurses, but we have advanced practitioners, physicians associates, allied health professionals, physios, OTs, pharmacists, and that entire team is now concerned with the delivery of unplanned care. We've heard already yesterday and today about the impact of COVID and how responsive we've needed to be as an organisation, as a local healthcare system and delivery, and with the rapid learning, the rapid changing guidance, and the need to keep patients safe, streaming of patients, all adds to the complexity of health delivery. So, Leeds Teaching Hospitals, that's where I'm based, that's why I'm giving this talk today. One of the largest trusts in the NHS. We're a major trauma centre. We're the regional hub for things like cardiac intervention, vascular surgery, stroke, HIV. Seven sites, 2 of them very large. We've got just over 2,000 beds, and we're in the process of building the new the hospital on the city centre site that focus on children's services. Wide variety of services, clinical service units, there are 19 of them. We provide secondary care to like a district general hospital to the people of Leeds, but also tertiary services for the region and quaternary services for patients from all over the country and indeed internationally. In all services apart from cardiac transplantation are represented in Leeds. Okay, the electronic patient record. We call it PPM+. In-house developed and as comprehensive as offer as commercially available software. We're really proud of the electronic patient record. In fact, one of my A&E colleagues, a guy called Tony Shannon, who is now very involved in informatics in the Republic of Ireland, was very instrumental in developing this. Cost around 5% of the cost of buying a commercial software. And as I said, just about as comprehensive. Started as Leeds Teaching Hospitals Care Record. It's now the Leeds Care Record with partner organisations around our city, and is now the Yorkshire Care Record. Not everybody, but many other organisations in Yorkshire are adapting and adopting this electronic patient record for the benefit of patients. It's a spine system, brings in over 100 different systems, and as you can imagine, we utterly depend on it. So the business continuity process for keeping the electronic patient record, PPM+, are robust. Just a thing about the West Yorkshire Association of Acute Trusts. So there's 6 trusts that are involved in that. There's Airedale, Bradford, Calderdale, Mid Yorks, Leeds, of course, and Harrogate. They are actually in North Yorkshire, but we consider them close enough to be West Yorkshire. There's real benefits of economies of scale for the Scan4Safety programme, and so that we can work as a collective when it comes to actually purchasing, but equally recognise the expertise within that group. So, for example, Leeds is leading on the Supply X element, but Airedale and Bradford are leading on the real-time location tracking piece, and there's a real shared accountability. So, the Scan4Safety programme. When I took over, and I've only been involved in the Scan4Safety programme for 15 months, taking over from Dave Berridge, who I'm sure many people in the audience may know. We had 14 different initiatives delivering on a range of avenues. And it took me a little while to get my head around it. And we had sort of some conversations both in the Leeds board and in the Wyatt board about sort of what are we trying to achieve, bearing in mind that the programme is time limited. So we turn to the sort of, our legal colleagues talk about the man on the Clapham omnibus as a test of reasonableness. These days it's probably better to refer to maybe the shopper in Sainsbury's. You know, the average person, the average citizen of the UK, and what would they think acute trusts are able to do? And I have asked a bunch of people, not all in Sainsbury's, but they would think that we know where our patients are. They would think we know where our equipment is, and they would be pretty sure we would be able to easily identify what piece of equipment or device we've put into our patients. Those are the 3 things that we're focusing on the Scan4Safety programme, because the general public think we're doing them already. So, the first one. This is a picture of the Ops Centre at Leeds General Infirmary, one of those 2 large sites I mentioned. And the live bed state is a real passion of mine. It's really the reason I got into this. And there's a big shout out for Mark Songhurst, who I don't know if he's in the audience. He's in the audience. I've just had 6 hands go up. I don't think they're all his. Maybe they are. I mean, he's capable of doing many things. So, you can see the Ops Centre doesn't look that techie. 2,000 beds in our organisation, about 85% of them are devoted to unplanned care. And of course, planned care depends on unplanned care not nicking their beds, yeah? So everything we do in unplanned care has a massive effect on planned care. If we got unplanned care right, planned care will be fine. So, we've got huge pressures. We've got COVID, we've got the COVID backlog, we've got winter pressures. We are running at 99.5% occupancy currently, or certainly in the early part of this week. And when we are in that situation, we have to come together in a sort of silver command. When people come together in the silver command, they bring their bed state on pieces of paper. And we are not alone in that. So we're in this situation of, as you get busier, you get less efficient. And we've got to change the paradigm for that. And in essence, the tagline is, make the right thing the easy thing. So, how difficult can it be? Give everybody a GSRN armband, which we do already, a wristband, either with emergency attendances, planned attendances, birth, and just put GLN everywhere. We've got 25,000 of these little plaques in all clinical areas, in non-clinical areas. My office door has one. Each cubicle in the toilet has one. They are everywhere. So how hard can it be just to put those 2 together? There is not going to be a test on this, ladies and gentlemen. It's really complicated. You know, sort of blue is the process, red is the information flow, green is the potential for improvement. But you can see it's not straightforward. So, what are we doing about it? Well, the first thing that we're doing is mapping every bed space. You know, I mentioned 2,000 bed spaces. It's unbelievably complicated because How many wards have bed 13? Not everyone. Some do, some don't. You would have thought that wards would number 1 to 30 or 28 or however many beds we have. Oh no, some wards do that. Others, well, it's A1 to 4, B1 to 4, C1 to 4. Mark has been pulling his hair out. Fortunately, it's grown back. Just to actually get where our beds are into the system is really important. But then we've got to be flexible, because the ward manager, the matron or the band 7, needs to be able to say, yeah, but you can't use bed 2 because the patient in bed 1 needs a hoist. Or that bay, we've had to close it for infection prevention reasons. So it's got to be responsive. But when we do get that, anybody seen Apollo 13, one of my favourite movies? Gene Kranz standing there in his waistcoat, directing the mission control, saving those astronauts with a massive bank of screens in front of him. And we initially thought that's what the command centre would look like, the ops centre. But in fact, it doesn't need to look like that at all. It just needs to have screens available that the clinicians or the clinical site managers can flick through to get some really crucial information. What beds are available now? What beds will be available soon? And how can we align the needs of the patient with what we're coming online in the next hour, the next 2 hours, the next 4 hours? Because if we get this wrong, we subject our patients to multiple moves. Now, there's a whole bunch of problems with that. One, a lot of those moves are out of hours. When I'm saying out of hours, I'm talking 10 p.m. to 7 a.m. So you're waking somebody up at 3 a.m. saying, I'm sorry, Miss, we're going to have to move you at 3 a.m. And if that person is confused, frail, it just causes untold harm to them, increases their length of stay. And we know that patient moves can add, a single patient move can add 2 days to that person's length of stay. It increases harm such as pressure sores, it increases harm such as falls, and is just a terrible experience. So we want to get away from that. We also we've got to get away from patients crowding in the ED, and this is a national problem. But again, well described, well documented, crowding in the ED directly results in mortality, increased death as a result of ED crowding. So we're causing harm by being inefficient. So, lots of reasons why our systems and having a live bed state can make things better. But we had a sort of system that came into being about 10 years ago, and nobody used it. And this is that recognition that any electronic system, any IT solution is only the bedrock. It is not the finished product. And it's all about people and how people interface with the system that we have. So enter the Leeds Improvement Method. Now, in 2015, 5 trusts entered into a relationship with the Virginia Mason Institute in Seattle, on the west coast of America, which is the global leader in health improvement, and they embraced the Toyota production system as from a lean methodology. And we have utterly embraced the principles that the Virginia Mason method into our Leeds Improvement Method. And it's about standard work, it's about board to floor sort of connectivity. It's giving the solutions to the people who know best about how to deliver that care, which are our frontline teams. And we are embedding the Leeds Improvement Method in any of the initiatives that we're utilising for Scan4Safety, and particularly for the live bed state, because we've got to do this with our teams directing us rather than telling our teams what to do. So that's about the live bed state. One of the other initiatives is the real-time location tracking, and this is now a shout-out to Stuart McMillan, who is in the room because I have seen him. So this is about knowing where everybody is on a granular level within a particular confine, within a specific space. So, for example, the emergency department. So in my clinical practice, I lead the department, but I also see my own patients. And sometimes I'll be reviewing, say, an older patient who's got some back pain, who looks otherwise well. So that person will be sitting in the waiting area, needs a clinical assessment by me. But I know that a small proportion of those patients will have something really serious as a cause of their back pain. They could have an aortic aneurysm, large blood vessel in the abdomen, gradually gets bigger and bigger and potentially could rupture. So I need to find this well-looking older person, bring them into a cubicle, find an ultrasound machine, bring that into the cubicle, assess my patient. If the department is really busy, which it usually is, it takes me ages to find my patient. I then have to find a cubicle. I then have to bring my patient to the cubicle, hoping that the cubicle hasn't been nicked by somebody else while I've been finding my patient. I then have to go and get the ultrasound machine. I have to find the ultrasound machine, bring it into the patient, and then do the scan. The whole idea of real-time location tracking is so that I know which cubicles are available, I know where my patient is, and I know where my ultrasound is. And of the 7 wastes, that automatically takes out 5 of them. So it's a really important element of our delivery of care to our patients that we can take out the wastes in that program. And we're going to, there's a wider piece across the organisation using RFID tags sort of through, whether it's passive or active. And as I said, Bradford and Airedale are well down that route. But it's a really important thing for our patients. The last stream that I just want to mention for a couple of minutes is our Supply X inventory management. And this is the piece where we've now established it in a number of theatres, gynecology, ophthalmology, breast, orthopaedics, where we can identify which device that which implant we're placing into which patient. We've got the procurement element of it. I'll come on to that in a sec. But we can then track back to understand what have we implanted in what patient. And certainly the pelvic mesh focus that's been going on for the last few months is a case in point. But it just also allows us to be far more flexible. It lets our surgeons really understand what their options are. It allows us to be just in time with the inventory management, and it means that we don't lose that, so we don't have that overproduction and inventory waste that are part of the 7 wastes of the Toyota production system. And it's not been straightforward. Certainly the platforms that we've been using to deliver Supply X have been slightly challenging with this transition from Android to the iOS Apple-based operating systems. But we've overcome all of those obstacles, and it is proceeding apace. And the clinicians involved and the wider multidisciplinary team in theatres are really, really supportive of the Supply X rollout that we've got. So I am going to finish ahead of time because I've got 2 minutes, 43 seconds left, and I won't need them all. So a few take-home messages. Message 1. A good idea at the time does not always last the test of time. And if it sounds too good to be true, then ... So a little healthy skepticism is a good idea is a useful thing to have when you're discussing sort of initiatives and program improvements, just to sort of put it through the lens of practical application. Teamwork, and I don't really mean teamwork as opposed within the sort of local Scan4Safety team. I'm talking about sharing work across organisations, across organisational boundaries. We've got some real benefits of having that strong relationship with the West Yorkshire Association of Acute Trusts. But sometimes, this is my car, you do have to put the work in. That's the consultant's car park. And lastly, just about sort of that standing back and sort of looking in the mirror. I used to do archery. I still do a bit of archery, actually, but when in my youth I was a bit more competitive, and the right-hand boss is a sort of example. And as you see, not all the arrows are in the custard. There's one in the top right, which is fine, because we're aiming to be outstanding, but we're not aiming to be perfect. Thanks very much.